నెక్స్ట్ బటన్ ఇది.
Yes, sir.
అంతే ఇది నొక్కాలా? Good afternoon, everyone. Today I'll present, I will be discussing how to approach clinically a patient with arthritis. I'm Dr. Sai Kumar, consultant rheumatologist and immunologist in Apollo Hospitals, Health City, Visakhapatnam. So, outline of my presentation will be, we'll be discussing a rule of thumb in any clinical case scenario when a patient sits in front of us, what we do usually, and we'll try to solve 11 questions of arthritis. By solving these 11 questions, we'll answer the following points: how to differentiate an arthritis and arthralgia, and what is the articular and periarticular pain, how we differentiate an inflammatory versus a non-inflammatory arthritis, since majority of our patients present with arthritis, but some of the features are not inflammatory in that case. Example for an osteoarthritis. And what is the pattern of joints, like whether it is a additive pattern or a migratory pattern, or it is a fleeting type of arthritis. We'll discuss what is the pattern of joints involvement, tell us, and the interpretation of duration of arthritis and the association with other extra-articular manifestations. How do we approach an arthritis based on these extra-articular manifestations? We'll be discussing. We'll at the end we'll see few examples. How do we usually approach it in a case of arthritis, and we conclude with that. So a general rule of thumb is that initially when a patient sits in front of us, we try to take their history, his or her story. We try to listen their story, and then we do a formal clinical examination, and we formulate a plan in our brain, and then we do an investigation. This is the order of order. This is the method what we follow and what we are taught even from our undergraduation. If we jump in any of these, like if we start doing investigations first and then take a patient history, specifically in a patient with rheumatological disease, for example, if a patient who is purely asymptomatic, and then you do an ANA and ANA comes positive, you don't know what to do now, since the patient doesn't have any of the findings, any of the clinical history or the examination findings. So rule of thumb is that we have to follow this a protocol, like taking a history and do a clinical examination, make a corroborative evidence with your history, and then do specific investigations according to your history and examination. So this rule follows even in case of a patient with arthritis as well. So solving a patient of arthritis is like solving an algebra. Like in algebra, it's like a mathematics, like 2 into 3 is equal to 6. The same thing follows here. If you simply answer these 11 questions in any case of arthritis, you can solve any case of arthritis, and you can come to a diagnosis and you can formulate your plan. So the first question what we ask usually is a demography. We take patient's age, gender, age, etc., and localization, onset, progression of arthritis, extent, nature of arthritis, pattern of involvement, distribution, presence of extra-articular features, and what is their family history, and drugs. So today I will solve these 11 questions one by one, and in these subsequent slides. First we'll see what how we deal with the demography. Why demography is important? Because when you know the patient age, some of the differential diagnosis will be ruled out and some of the diagnosis will rule in. For example, if the patient of age is less than 16 years, I will think of juvenile idiopathic arthritis. If his age is above 16 to 17, we consider him as an adult and treat like an adult arthritis. And if a patient with a low backache comes to me in Along with it, early morning stiffness also will be present. In case of an arthralgia, there is no evidence of cardinal signs of inflammation. So coming to the next question, localization. So when we see a case of arthritis is articular or periarticular. So what are the differences between an articular and a periarticular pain? In case of an articular pain, the anatomic structure which is involved is synovium, cartilage, and capsule. In case of periarticular, tendon, ligament, bone, and muscle. So for typical example of a periarticular pain, you can imagine a frozen shoulder where it is predominantly as we know, the pathology in case of periarticular pain is a bursitis, or it is an adhesions involving the rotator cuff, which is a composite of a ligament and a muscle. So for example, for articular, you can typically think of a knee, which is a knee swelling in case of a rheumatoid arthritis. So in case of an articular swelling, it is predominantly synovium, cartilage, and capsule which is involved. In case of periarticular, it is predominantly tendon, ligament, or bone. In case of articular arthritis, a painful site is diffuse and deep. And in case of periarticular, the painful site is usually focal. And patient, if you ask the patient to point with a finger, he can point at the specific site. But in case of an arthritis, he will try to show with this type of movement. He will totally cover the joint with both hands. Pain on movement. In case of a typical arthritis, the all range of movements are painful, but in case of periarticular pain, the movement in particular joint is only particular movement is only painful. And in articular, there can be arthritis, will be swelling will be there, but in case of periarticular, the swelling is uncommon. And palpatory findings similar to that of painful site, like it will be a focal tenderness in case of periarticular, whereas in the articular, it is diffuse tenderness can be seen. Next question we'll try to answer is, what is the onset of arthritis? If the onset of arthritis is less than 6 weeks, we consider this as an acute arthritis. And if this acute arthritis is involving a single joint, we call it as monoarthritis. And whenever there is a monoarthritis, we should think of septic arthritis, gout, or pseudogout. In case of an acute polyarthritis, the most common differential diagnosis is a post-viral arthritis. In case of if the arthritis is crossing more than 6 weeks, and if there is a polyarthritis and monoarthritis, we have to think of other differentials like rheumatoid arthritis or spondyloarthritis. If it is more than 6 weeks and a monoarthritis, anytime we have to rule out tuberculosis associated with this arthritis. And next we'll discuss how the progression matters in case of arthritis. In case of progression, usually it can start with a single joint and then start involving the other joints as well, which is typically a additive pattern of arthritis. Like for example, in a patient with rheumatoid arthritis, the arthritis can start with knee and then subsequently it can involve the other joints as well. So like right knee followed by left knee, and then involves first and second MCP as well as third and fourth MCP similarly. Or it can be a migratory arthritis where the symptoms are present in certain joints for a few days and then remit, only to reappear in other joints. This typical pattern can be seen in palindromic onset of rheumatoid arthritis, Whipple's disease, gonococcal arthritis, rheumatic fever, and early phases of Lyme's disease. The previous example I was discussing, which is the typical additive arthritis, where in which you will have a single joint. Before that joint resolves, the other joint involvement also starts. This is a typical example of a rheumatoid arthritis type of presentation. The other diseases which can present similarly are SLE and osteoarthritis. Intermittent arthritis, this is a repetitive attacks of acute polyarthritis or often oligoarthritis with complete remission between attacks. The typical example for this is a gout, where each time the patient tend to have a single joint involvement, typically involving the metatarsophalangeal joint, MTP joint. In case of polyarticular, this can come as a bouts involving all tarsal joints or involving the all digits. The similar type is a pseudogout. Pseudogout also can present as an intermittent arthritis. So the next question we'll try to answer is the extent of arthritis. For example, extent meaning how many number of joints are involved. If a single joint is involved, it is monoarthritis. If 2 to 4 joints are involved, it is oligoarthritis. If more than 4 joints are involved, polyarthritis. So we have to we have to ask the patient, if the patient, when we are examining, if the patient has only single joint, we have to diligently take their history, asking for previous joints involvement. So to say whether it is a polyarthritis or an oligoarthritis or it's a monoarthritis. So then the nature of joint, whether it is inflammatory or a non-inflammatory type of pain, so that we have to discuss. Because inflammatory, usually it is associated with early morning stiffness more than 30 minutes, which is not present in case of non-inflammatory arthritis. And inflammatory arthritis is associated with constitutional symptoms, and there is a and pain worsens usually after prolonged inactivity, whereas in non-inflammatory it worsens after prolonged use. For non-inflammatory, the typical example what we commonly see is the osteoarthritis pain, where patient tells after, by evening, after he does his majority of their work, then their pain worsens. Whereas in case of a rheumatoid arthritis patient, he tells pain predominantly in the early morning after getting up from sleep, which is a prolonged inactivity. And locking and instability, which is a predominant feature of non-inflammatory arthritis, but is not seen in case of inflammatory arthritis. On examination, we can see signs of inflammation in case of inflammatory arthritis, but not in case of non-inflammatory arthritis. Tenderness and signs of inflammation and multisystem disease are usually seen in inflammatory arthritis, but not in case of non-inflammatory arthritis. The next question we'll try to answer is the pattern. So why we have to know the pattern of arthritis is that we have to see, whenever we examine the patient, we have to see whether the arthritis is deforming or non-deforming. It radiologically transmits as an erosive or a non-erosive arthritis. So why we have to differentiate is that typically the CTD arthritis are non-erosive. I'm by meaning CTD, I mean SLE, Sjogren syndrome, or myositis. Associated arthritis are usually non-erosive. That means there are non-deforming arthritis. So whenever you see a patient with deforming arthritis, we have to consider predominantly rheumatoid arthritis, spondyloarthritis, crystal-related arthritis, and in few cases of mixed connective tissue disease. So if a patient with a chronic arthritis illness for 15 years come to you with a flare of arthritis and he has deformities, if there is no other extra-articular manifestation, he is by sure can be confirmed as a case of rheumatoid arthritis, and there is no point in doing a rheumatoid factor and anti-CCP to confirm your diagnosis, because the most common cause of deforming arthritis is rheumatoid arthritis. So after this, we try to solve this. We'll see for the distribution of arthritis. So what I mean by distribution is whether it is predominantly axial skeleton or the appendicular skeleton which is involved. Appendicular skeleton is most commonly involved in case of rheumatoid arthritis or CTD related arthritis. Axial skeleton involvement is seen in case of psoriatic arthritis, spondyloarthritis, enteropathic arthritis, as well as Behçet syndrome. In few cases of Behçet syndrome and crystal related arthritis. And next, we have to see whether it is predominantly a large joint arthritis or a small joint arthritis, because amyloid arthritis is predominantly a large type of arthritis, whereas in case of a rheumatoid arthritis, it is predominantly small joint arthritis. In spondyloarthritis as well, it commonly involves large joints over the small joints. And we have to see whether it is involving predominantly upper limbs or lower limbs, because rheumatoid arthritis, once again, it is predominantly upper limbs, whereas in case of spondyloarthritis it is predominantly lower limbs, and in sarcoidosis also it is predominantly lower limbs. And then we have to see whether the arthritis pattern, whether it is symmetrical or asymmetrical, because symmetrical presentation or asymmetrical presentation can help us in in formulating a set of differential diagnosis. So for example, in case of symmetrical involvement, if it is inflammatory arthritis, examples are rheumatoid arthritis, SLE, polymyalgia rheumatica, rheumatic fever, sarcoidosis, and adult onset Still's disease can present as symmetrical inflammatory arthritis. If there are no features of inflammatory, it means a non-inflammatory arthritis, and it is symmetrical, still symmetrical, it can be osteoarthritis, CPPD, or a hemochromatosis associated arthritis. In case of a symmetrical arthritis, and if it is an acute and less than 6 weeks duration, it can be a post-viral arthritis. And in miscellaneous causes, this hypertrophic pulmonary osteoarthropathy and hypothyroidism can present as a symmetrical arthritis. In case of asymmetrical inflammatory arthritis, most common differentials are spondyloarthritis, composing angstpon, reactive arthritis, psoriatic arthritis, enteropathic arthritis, and JAE. In case of non-crystal related arthritis, gout and pseudogout can present as asymmetrical because these are usually single monoarthritis type of illnesses. And in case of asymmetrical infectious arthritis, bacterial endocarditis, Lyme's can present as asymmetrical arthritis. So the next question we try to solve is the presence of extra-articular manifestations. So what are the extra-articular manifestations which can be associated with an arthritis are rheumatoid nodules, erythema nodosum, psoriasis, uveitis, sicca, dental caries, purpura, and malar rash. These are some of the examples of extra-articular manifestations we can see in a patients with arthritis. So subsequent slides we will see what are the common extra-articular manifestation if present with arthritis, what are the differential diagnosis. So for example, if a patient has a fever with arthritis, so the most common differential we consider is SLE, others is post-viral arthritis, vasculitis, rheumatic fever, adult onset Still's disease, and brucellosis. And other is IBD related arthritis and sarcoidosis. So if the patient has an arthritis with significant muscle weakness or myalgia, we will consider polymyositis, vasculitis, SLE, rheumatoid arthritis, hypothyroidism, and viral syndrome as our differential diagnosis. For example, a patient you have seen in the OPD with arthritis, and she has this Raynaud's phenomenon as well. So the first differentials which will come to my mind are scleroderma, SLE, Sjogren syndrome, rheumatoid arthritis, and inflammatory myositis. For example, if I see an arthritis patient with this type of oral erosion, palatal erosion, or in that case, if I see this type of an aphthous ulcer involving a tongue, or this aphthous ulcer involving the hard palate or gingiva, or the tonsillar folds. So my differentials will be whether, well, I'll ask the patient whether they are painless or painful. If they are painful, the differential we consider or is this Behçet's disease. If it is painless, it is predominantly SLE, reactive arthritis, or enteropathic arthritis. In this case, the first figure, the patient is an most common is an SLE, and it is the most common association, the hard palate erosion, which is a common association with SLE. So next we'll see what are the eye manifestation associated with arthritis. The most common is in case of Sjogren syndrome is a keratoconjunctivitis sicca, which can be seen in Sjogren syndrome, which can also be associated as a secondary Sjogren syndrome with rheumatoid arthritis and SLE as well. And uveitis as a presentation with arthritis can be seen in spondyloarthritis, sarcoidosis, Behçet's disease, and GPA, ANCA-associated vasculitis. And this is a case of ciliary staphyloma, in which the patient had recurrent scleritis followed by scleral thinning, and this anterior chamber is about to perforate in this patient. Like this, there is a formation of ciliary staphyloma because of thinning of sclera. So secondary to recurrent scleritis. This patient is subsequently went on, we have diagnosed as a GPA. And the other common association with scleritis are rheumatoid arthritis and SLE. So other presentation is a retinal vasculitis, where SLE, Behçet's disease, and rheumatoid arthritis patients can present as retinal vasculitis as well. Coming to arthritis and lung, if the patient tells you has a symptoms of hemoptysis, you think of ANCA-associated vasculitis or rheumatoid arthritis, because rheumatoid arthritis can have bronchiectasis and then they can present with hemoptysis. And if the patient has arthritis along with pleural effusion, the differentials considered are SLE and rheumatoid arthritis. If there is a ILD coexisting, the differentials are scleroderma, inflammatory myositis, and rheumatoid arthritis. If there is a pulmonary hypertension associated, the differentials are scleroderma, inflammatory myositis, and vasculitis. So whenever you see a patient of arthritis, we have to take a detailed systemic evaluation, because we have to see for the detailed system involvement involving the pulmonary, respiratory, as well as neuropathy, neurological involvement, as well as renal involvement and gastrointestinal involvement. So if the patient has a neurological involvement associated with arthritis, SLE vasculitis, rheumatoid arthritis, amyloidosis, and cryoglobulinemia will be a possibility where the patient can present as mononeuritis or mononeuritis multiplex or an AMAN like GBS type of presentation. If there is a renal involvement, most common association is SLE, where the patient can present with proteinuria, hematuria, and hypertension. Oncovasculitis patients, they can present as hematuria and worsening serum creat. And the patients with polyarteritis nodosa can present with renal artery aneurysms. And patients with gout can present with renal caliculi, and they'll go to asymptomatic progression to CKD. In case of Sjogren's syndrome, patient can have renal tubular acidosis, and in case of Behçet syndrome, similar to that of a pan, they can have an aneurysm or they can have a renal artery or a renal vein thrombosis. In case of rheumatoid arthritis, the renal involvement it can be in the form of amyloidosis. Angst-bound patients can have IgA type of vasculitis as well as membranoproliferative nephritis. In reactive arthritis, it is predominantly renal involvement is in the form of an UTI. GA involvement can be seen in patients with scleroderma, where they can present with pseudo obstruction as well as anal incontinence, as well as infective short bowel uh, growth syndrome. In case of an SLE, patient present with GA vasculitis. In case of enteropathic arthritis, the patient can have a Crohn's or IBD, Crohn's or ulcerative colitis. And in PAN and Behçet, this is again the patient can present with a GA vasculitis. So next we'll be seeing some of the clinical scenarios. So if I see a patient with this type of malar rash and there are small vessel vasculitis changes involving palms and with an inflammatory arthritis, my diagnosis will be an systemic lupus erythematosus. There is no point in doing subsequent investigations, and then we'll go ahead and evaluate only for the other organ involvement, like what we have discussed, whether she has a renal involvement, lung involvement, or cardiac involvement. In these lines, we will work up. So there's no doubt in the differential diagnosis, in diagnosis with this manifestations. So if another case scenario, this is a 52-year-old female who had presented with arthritis, and she had presented with hyperkeratotic, hyperpigmented, hyperkeratotic rash, scaly rash involving the ulnar aspect, involving the radial aspect of digits in predominantly the index fingers on both sides. This is a mechanic's hand. This is an example of a mechanic's hand. It is associated with ILD, and if the patient has arthritis, my diagnosis will be an antisynthetase syndrome. In this, we can avoid doing a myoblot, which is a 10,000 rupees for the patient. So, because a diligent clinical examination with clinical findings will give us a diagnosis in this patient. For example, in this patient, you can see a deforming arthritis, which is bilateral symmetrical, probably was an additive arthritis, and you can see it is a deforming arthritis, and is associated with a nodule on the elbow. So, which is a typical of a rheumatoid nodule, and the diagnosis will be rheumatoid arthritis in this case, which is straightforward when we see these typical type of deformities. So in this case, a patient presented with arthritis, inflammatory polyarthritis, and if you can see, there is an oral sicca, and this is geographic tongue what she had. And if you see clearly, she has dental caries involving in between the teeth. So this is a typical dental caries which will happen in Sjogren's syndrome because of decreased saliva production and inability of the saliva to clear the food in between the teeth. So typical dental caries location will be in between the teeth, not involving the crown or in the molar region. It is predominantly these teeth which are involved. And when we examine her for dry eye, she has Schimmel's positive. So the diagnosis will be Sjogren's syndrome. So if you can see, this single picture gives us a diagnosis as well as the burden of the disease as well, and various manifestations associated as well. If you can see this in this single picture, patient has plaque type of psoriasis. These are hyperkeratotic plaques with scaling, as well as if you can see there is a swelling involving the little finger, and it is involving both proximal interphalangeal joint as well as distal interphalangeal joint, and this is asymmetrical, and there is no this side there is no involvement. There is a minimal involvement here in this PIP joint, and the involvement is not symmetrical, it is asymmetrical, which is a typical of a spondyloarthritis. Psoriatic arthritis is spectrum of spondyloarthritis, and by seeing this single picture you can diagnose this patient as a case of psoriatic arthritis. So there are some other specific pointers in different diseases. For example, if a lady comes to me with inflammatory backache with uveitis, and then she has this painful swelling involving this both heel region, this is a tendo Achilles, and if there is a swelling erythema, and there is an erythema which you can see clearly, and there is swelling as well, you can clearly see her tendo Achilles is swollen. This is an enthesitis. So no doubt I can diagnose her as a spondyloarthritis. And this is, and in this figure you can see this is a sausage type of swelling involving the tarsal joints. This is like a chicken sausage. So this is called dactylitis. Whenever it is there, the diagnosis is spondyloarthritis. Other diagnosis we should consider, if there are no other findings, are sickle cell disease as well as sarcoidosis and tuberculosis. These are the common differential diagnosis for dactylitis. And if the patient has an inflammatory arthritis with malar rash and this type of scarring alopecia, this is a daily lesion with scarring alopecia involving face. No, I will straight away write my diagnosis as systemic lupus erythematosus with DLE and inflammatory arthritis. So other thing, this, as you can see, this is a salt and pepper pigmentation involving over the dorsum of hand. And if you can see, these are not arthritis, these are actually the digits are being shrunken at the tips. So this is a typical example of a complicated Raynaud's with, and you can see her skin is shiny and glossy and thickened. This is a case of scleroderma with Raynaud's, complicated Raynaud's, and there is a contractures, there are contractures in the palmar aspect which is causing these joints to bend over, and there is a salt and pepper pigmentation as well. And as I have shown you earlier, this is a typical presentation of a SLE wolf like malar rash involving the both malar area and in the face as well. This is an acute type of rash, and the similar type of rash can be seen in case of dermatomyositis as well. They can also have a malar type of rash, and the other finding what you can see is they will have a diffuse hyperpigmentation involving the forehead as well. This is another specific point as what we can see. So I didn't want to disclose, there is a heliotrope sign in this patient as well involving, because you can see here there is a periorbital puffiness. I didn't want to disclose, so I have closed her eyes. So this is an example of a dermatomyositis patients, a patient who has a typical malar rash which is similar to that of an SLE, but they will have a diffuse hyperpigmentation with a heliotrope sign. So these are the specific pointers we can have when we have to look for when we see a patient with arthritis. So the other last but one question is a family history, because presence of a first degree relative with an autoimmune connective tissue disease or an autoimmune rheumatic disease or either any other autoimmune disease like hypothyroidism, which will give us an evidence of an ongoing autoimmunity going in the family, which is running in the family. For example, rheumatoid arthritis, the coincidental risk in a first degree relative is which varies from 30 to 45%. And in case of osteoarthritis, also similar, the family history plays an important role. If there is a family history of early onset osteoarthritis, and you are seeing a patient with non-inflammatory arthritis involving bilateral knee, and you have to think of osteoarthritis which has developed early in this patient. Other thing is strong history of psoriasis, because majority of asymmetric oligoarthritis patients may not have, approximately 15% may not have coexisting psoriasis at the time of presentation. But when you ask their family history, if there is a presence of psoriasis in first degree relative, you treat them as psoriatic arthritis, as a high risk for psoriatic arthritis. As I said earlier, hypothyroidism, which is like a 40% association with all our autoimmune connective tissue diseases. So the next thing what we have to ask is for drugs, because asking drug history is important, because in this era of like we give the patient may be on beta blocker or AC inhibitor, or he's on diuretics for hydrochlorothiazide, or he's on like anti-tubercular drugs, which can cause a drug-induced lupus-like picture. And if the patient is on ciprofloxacin or any norfloxacin or quinolone drugs, which is predominantly in children, they can present as arthralgia. Other drug which can present with arthralgia or interferon, this is now not currently being used in case of hepatitis B or hepatitis C treatment, where previously it was like 10 years back, which was there was a increased use of interferon for hepatitis B and hepatitis C chronic. So the patient used to present with flu-like symptoms and arthralgia. And pyrazinamide, which is the anti-TB drug, which can present with arthralgia. The other drugs like diuretics, aspirin, and cytotoxic agents, if they are used, then can present with gout. Allopurinol thiazides and thiazide and septrin can present with vasculitis. They can present as drug-induced vasculitis or Stevens syndrome, typically with allopurinol. Scleroderma like presentation with skin thickening can be seen with coexisting use of bleomycin or pentajocin. And in use of glucocorticoids and bisphosphonates can increase the risk of osteonecrosis. So for completion, I would like to tell two cases of monoarthritis which can present, like a 50-year-old lady who was admitted in post-transplant ICU. She has undergone a renal transplant for her CKD, secondary to diabetic nephropathy, and she was referred to us for new onset pain, swelling, erythema, local warmth, tenderness involving left third PAP joint. So this is a typical presentation of a monoarthritis involving only single joint. You can see here there is a signs of inflammation. So what is the typical, what differential I would consider in this patient is a septic arthritis, because this is a post renal transplant patient and she's on immunosuppression and she's elderly and she has other two immunosuppressive conditions like CKD and diabetic nephropathy. So which will point more towards a septic arthritis in this patient, and since she's in ICU as well, so which will point me towards more of a septic arthritis rather than any other arthritis. My approach will be aspiration of this joint and send for cultures and then start on antibiotics. The other example of a monoarthritis is a 70-year-old hypertensive man comes to ER with swollen and sore great toe, and he was woken up by symptoms of complaints of severe pain. No other joints are involved, and prior to this evening he had a dinner for his reunion party he had with his friends. So this is a typical history of gout where a patient has a high calorie diet and with probably alcohol and high protein containing diet, uh, which has precipitated an attack of gout and typically involving a metatarsophyllangeal joint. So these are the contrasting pictures what we can see in monoarthritis. So in every case of monoarthritis, we have to aspirate the joint and send for cultures. Unless proven otherwise, we should never, we have to always rule out septic arthritis. And for a single example of oligoarthritis, this is a 32-year-old female who had bilateral ankle arthritis and has presented with skin lesions with erythema nodosum involving bilateral feet. So in this condition, the differentials what we consider are sarcoidosis, tuberculosis, enteropathic arthritis, and Behçet's disease. So I would like to give an example of an oligoarthritis where they can present as like this also, like erythema nodosum with ankle arthritis, where the differentials we'll consider are these four: sarcoidosis, tuberculosis, enteropathic arthritis, and Behçet's disease. So for conclusion, I would like to take this help of this excellent flowchart given in Harrison, where if the patient had any musculoskeletal complaint, the first four questions we'll ask are whether it is articular and whether it is acute or chronic, whether there are signs of inflammation, and how many joints are involved. These are the four questions we'll ask, and then we'll go to the next step. Is it acute, focal, or monoarticular? If it is monoarticular, if your answer is yes, then you have to consider your differentials as gout, septic arthritis, and vascular ischemia or carpal tunnel syndrome. If it answer is no, then you have to ask whether the arthritis is articular or periarticular or non-articular. If non-articular conditions, you have to consider trauma, fibromyalgia, polymyalgia rheumatica, bursitis, tendinitis, and myopathy or myositis. If it is articular, then you will have to ask the next question: what is the duration of arthritis? whether it is acute or chronic. If it is acute, our differentials will be infection related or crystal related predominantly. Whether it is a septic arthritis, gout, or pseudo gout, or reactive arthritis will be our differential diagnosis. If it is chronic arthritis, we have to ask for signs of inflammation. If there is prolonged signs of inflammation like morning stiffness, and is there tissue swelling, are there systemic symptoms, or there is a presence of extra-articular symptoms, and what is the value of ESR CRP. So for, since my talk is on clinical approach, I didn't go into the investigation aspect, but if ESR and CRP elevation will point us towards an inflammatory arthritis. If our answers are yes, we consider it as chronic inflammatory arthritis, and if it is no, we consider it as chronic non-inflammatory arthritis. The differentials will be osteoarthritis, hemochromatosis, and Charcot-related arthritis. If our answer is yes and it is a chronic inflammatory arthritis, then we have to ask the further question: how many joints are involved, whether it is oligoarthritis or it is a polyarthritis. If it is polyarthritis, whether it is symmetric or asymmetric, whether it is deforming or non-deforming. If it is deforming, then the differential will be rheumatoid arthritis. If it is non-deforming, our differential will be SLE, scleroderma, and polymyositis. If it is oligoarthritis, as we discussed earlier, our differential will be spondyloarthritis. So this is a good flow chart which is there in Harrison in the chapter of approach to arthritis, which can be referred subsequently. So in conclusion, diligent history taking, demography, duration, and progression of symptoms will help in understanding and evaluating a patient of arthritis. This will decrease the investigative burden on the patient as well. And we must follow the order like history, clinical examination, followed by investigation, rather than doing investigation and then taking up history and doing a clinical examination. And we should always look for hidden areas for extra-articular manifestation, specifically for salt and pepper pigmentation, which can be hidden in scalp or behind the ears or on the nape of neck. And in for scarring alopecia, where patient has to disclose herself for scarring alopecia, because female, which they tend to cover these areas. And in case of psoriasis, we have to specifically check behind the ears and in the buttocks and in the lumbar area, which are the hidden areas for psoriasis, where patients may not see, or may they won't disclose by themselves. We have to uh, probe them and ask for the areas of psoriasis. And uh, we have to answer and to diagnose a case of arthritis, we have to follow these 11 questions and answer these 11 questions, and your job with approaching a patient with arthritis is done. Thank you.